afternoon from wherever you might be joining. Yeah, good morning once again. From wherever you might be joining. It's a pleasure to welcome you to this second edition of the ECOWAS Research and Development Lassa Fever webinar series. And as you may know, this webinar edition is focused on strengthening community-based research for Lassa fever prevention and control, and it is proudly hosted by the West African Health Organization. I would like to say to begin with that this webinar is really a pivotal moment in the region's efforts to combat the persistent threat of Lassa fever, particularly within this region. And as we've seen in recent years, that Lassa fever continues to challenge us in many ways. But through collaborative research, community engagement, we are making giant strides. So this webinar series is focused on exploring how local insights and partnerships can enhance surveillance, prevention, and treatment strategies, from things like vaccine development to community-driven surveillance. We have realized that every aspect of the response and preparedness is all about integrating local knowledge and local practices. So today, I am proud to say that we'll be hearing from many experts who have spearheaded community-based research across the different endemic countries. And today they'll be sharing with us some of their methodologies, some of their successes and lessons learned, and highlighting how these initiatives can help influence better response to the Lassa fever disease. Today, some of our presenters will be showcasing some insightful case studies, and we also have a very robust panel discussion with the different speakers that we'll be introducing later on. And at the end of today's session, we hope that we are able to deepen our knowledge, our awareness, and chart actionable steps towards integrating some of these community-based insights into some of the policy and practice that we do as we continue to fight the Lassa fever disease. At this point, we have a short poll that we would like to pull up now. Basically, this poll is to request that we share some of the expectations that we hope to gain, some of the insights we hope to gain from this webinar. And I will leave the poll on for about 2 minutes. I hope everybody can see the poll. And I'll request that we just talk about what we expect to gain from this webinar, and in just 2 words. My fellow panelists, I hope you can see the poll. Can I confirm that you can see the poll?
Yes. Yes, we can see the poll.
Okay, all right. Yeah. So while we wait for people to fill the poll, okay, I see a lot of people filling the poll now. At this point, I would like to invite Dr. Virgil Lupuso, who is the Acting Director for Healthcare Services at WAHO, for the opening remarks. Dr. Virgil, sir, over to you, sir.
Thank you so much, Ibuku, for the opportunity. Good afternoon, good morning, colleagues, from whenever you are. It's really a pleasure for me to recognize all attendees of this today's session, and also to deliver a small speech on behalf of the WAHO DG, who would have loved to join us today, but because of conflict of agenda, he's not here. So, distinguished experts, guests, and participants, I just want to, before starting speaking, I just want to let you know that we have interpretations. You have a button on your screen you can click on to see the appropriate language you want to hear this conversation in. It's really important that you feel confident on the platform to exchange network with all stakeholders attending this webinar. So it's actually our second webinar, and it's really my pleasure to welcome you on this important webinar. And the topic today is to strengthen community-based research for prevention and control of Lassa fever. As you know, Lassa fever remains a significant public health threat in West Africa, posing several health, economic, and social challenges. Despite ongoing efforts, outbreaks continue to occur, emphasizing the need for effective preventions and control strategies that are rooted in community engagement and evidence-based research. Today, we gather on this webinar to discuss crucial aspects of Lassa fever control, the power of community-based research. By working directly with affected populations, strengthening local surveillance, and integrating traditional knowledge with scientific research, we can develop more sustainable, context-specific, and impactful solutions to combat Lassa fever. This webinar is truly an opportunity to exchange ideas, share best practices, and explore innovative approaches that place community at the head of our prevention and the response. We will hear from experts and practitioners who have first-hand experience in conducting research that not only enhances scientific understanding, but also empowers community to take ownership of their health. I encourage all of you to actively engage and participate, ask questions, and ensure meaningful discussions on this platform. Your contribution will help shape the way we strengthen research, enhance surveillance and disease control, and ultimately health systems to reduce the burden of Lassa fever in our regions. Thank you for joining us today. I don't want to be long. I wish all of us an insightful and impactful conversation going forward. Thank you so much, Ibuku. I'm glad that we are over 100 participants on this platform. It's really a privilege to know that we have more awareness and more demand to engage in the discussions. Thank you, and over to you, Ibuku.
Thank you so much, Dr. Virgil, for sharing those really insightful remarks. And also thank you to all the people that have filled the poll. I'll still leave it on for a couple more minutes just to encourage everyone to fill that poll as much as they can. So at this point, I would like to invite the moderator for today's session, Oloma Major, to take over. Thanks.
Good afternoon, everyone. Good afternoon, everyone. Good afternoon, everyone. I would just start off by speaking to the objectives, touching on some of the objectives that Dr. Virgil had. That Dr. Virgil had also highlighted, but just for it to be able to set a pace for us while we start to take some of the case studies and get into the panel discussion. So the webinar in itself has three main objectives that we would be that will shape the discourse for today. And the first one is, the very first objective would be to showcase the case studies of community-driven research on Lassa fever, and we'll have our speaker that would be doing that very shortly. And then we would also be highlighting some methodologies for community-based, community-driven research as it relates to Lassa fever and Lassa response as well. And then the third one, to identify opportunities for scaling community-driven research within the ECOWAS region and also at the national levels as it relates to Lassa prevention and control strategies in the region. So for us to take on the discourse from on here, I'm going to invite our first panelist and presenter to discuss while my team is putting up her presentation. So we would have Dr. Ekaete Tobin for the presentation. She's a researcher at the Institute of Lassa Fever Research and Control at the Irrua Specialist Teaching Hospital. Over to you, Dr. Ekaete.
Thank you very much. Thank you for having me. My name is Dr. Ekaete Tobin. I am a consultant public health physician with the Institute of Lassa Fever. It's actually Institute of Viral and Emergent Pathogens Control and Research, Irrua Specialist Teaching Hospital, Nigeria. And I'm waiting for my slides to show. Thank you very much. So I'm going to run us through a few studies that we've been carrying out in our center here. Can you go to the next slide, please? All right, so I have the first one here. The title is Proprietary and Patent Medicine Vendors in Lassa Fever Endemic Communities in Edo State, Nigeria. Assessment of knowledge, exposure risk, and potential for inclusion in outbreak response. We sought to determine the knowledge and attitude that patent and proprietary medicine vendors have about Lassa fever. Sorry, please, can I have the slides on again?
Can you see it now, Dr. Ekaete?
Yes, thank you. I can see it now.
Sorry about that.
Thank you. I think you blocked it. So, so I was saying we sought to determine the knowledge and attitude proprietary and patent medicine vendors have to Lassa fever, ascertain their exposure risk based on the practices they carry out in their retail shops, and then investigate what the potential role they have in community-based Lassa fever control. It was a cross-sectional study carried out in Esan West and Esan Central local government areas, two Lassa fever high reporting local government areas in Edo State, Nigeria. We used self-administered questionnaires and we targeted 200 patent and proprietary medicine vendors. We got ethical approval and we got them to consent to participate in the study. For results, we got a response rate of 91%. So out of the 200, 91% participated in the study. All of them were aware of Lassa fever, so they had previously heard about Lassa fever. However, when we assessed their knowledge based on parameters we had captured from literature search, we found out that, and from the experiences we've had, only about 64.8% had adequate knowledge. And when we ran the logistic regression, having tertiary education and being older than 35 were indicators of predictors of good knowledge. towards Lassa fever. For attitude, 60.4% of them had a positive attitude, in the sense that about 74% recognized Lassa fever as a public health problem. 45% felt the risk that they could perceive that they could contract Lassa fever from their clients. 75 were favorably disposed towards training and raising awareness of Lassa fever among proprietary and patent medicine vendors. 30% felt they could identify a case, and only 60% had the perception that they should not be they should not treat Lassa fever. So we also found that 74.2% were willing to educate clients on Lassa fever if they were empowered to do so. For practice, 66.5% had used a sharp device in the 6 months preceding the study. And for this number, 33.9% was actually an injection device. So either it was a syringe and needle or a lancet or other sharp instruments. So what we got from all this analyzing their risk practice were that practices were suboptimal for injection safety, for use of hand gloves, for hand hygiene and waste management. So we concluded this study by saying that Lassa fever and patent and proprietary medicine vendors should be included in training programs, because there was a real potential for them to be part of the response and to support at local government area, and this potential should be explored. Next slide, please. Next slide, please.
Okay, the next slide is coming up. We're trying to project the second slide due to the changes in the document. So just a couple of seconds. I will be open. Okay. Please go to the second slide, the very previous one. Right. Dr. Ekaete, can you see?
Yes, I can, but I've taken this slide, so maybe the slide before. Okay, right, that's fine. This one. So we also had this study in 2015. We titled it Lassa Fever in Nigeria, Insights in Prevalence and Risk Factors in Rural Edo State, a pilot study. Here we sought to investigate the prevalence of risk factors at community level, risk factors for Lassa fever, and get a sense of the Lassa seroprevalence in Esan West, local government area of Edo State, Nigeria. Esan West has always been one of the high reporting, one of three very high reporting local government areas in Edo State. And as you know, Edo State is the second state with the second highest burden of Lassa fever, correct, in Nigeria. So we had 176 respondents participating in this study, and which, like I said, we carried out in those states. And we sought to investigate individual and household risk factors. So at household level, we would ask the head of household or his representative to give us information about the household risk that members face. Then we'll take members of that household and interview them on their individual risk that, for Lassa fever. We also collected blood for antibodies, Lassa specific antibodies, IgM and IgG, which we analyzed using ELISA in our laboratory here in the Institute. So when we ran our results, rodent presence was 96.1% of houses had at least a rodent, presence of a rodent, either by smell or excreta or physically seeing a rodent in the house in the past 6 months. Gari consumption, this gari meal, gari soaked in water meal was a frequent one. By 58.4% of people did consume a gari meal the past few months of the study. Hunting of rodents was also a practice that came up with 29.9% of people agreeing to that. And then when we ran the analysis using ELISA, we got the prevalence of IgM was 1.3%, while IgG was 58.2%. So we deduced that we need to heighten public enlightenment, particularly of the risk practices that were prevalent in these communities, to drive down the incidence of Lassa fever. Next slide, please. Now, more recently, we've had two studies that have covered more of the more states in Nigeria than the ones just the two states. So we have the Enable 1.0 study, which started from 2020, and it was a multi-center study, 5 countries, including Nigeria, and in Nigeria, 3 sites, including Edo State. The overall aim of the CEPI Enable 1.0, which was the sponsor, was sponsored by Coalition for Epidemic Preparedness and Innovation, CEPI, was to inform the design of a phase 2B or 3 Lassa fever vaccine trial, identifying the sites, strengthening site capability and capacity to carry out the trial, and also provide objective information that would guide vaccination strategies. But particularly for Enable 1.0, the study aimed to estimate the age and sex-specific incidence from Lassa fever disease and Lassa fever infection. So both the asymptomatic and symptomatic cases. We enrolled 5,000 people in Edo State across 7 hotspot clusters, 3 high-reporting local government areas, followed them up for 2.5 years, and we had 2 cohorts. So you had a disease cohort of 5,000, then a nested cohort called the infection cohort of 1,000. The disease cohort were followed up every month using physical visits for 2 weeks and a bi-weekly physical visits and phone calls. Then the infection cohort was bled every 6 months to check for seroprevalence of Lassa fever. This study ended, and then it has rolled into Enable 1.5. Please, next slide. Again, 1.5 is another community-based study, just as 1.0 was. Again, still to evaluate the Lassa fever incidence, Lassa fever symptoms, and co-infection with malaria in West Africa. The objectives were essentially of 1.5, which has been narrowed down to 3 countries, and in Nigeria, 3 sites, including Edo State, is to assess the incidence rate of symptomatic Lassa fever disease, assess the utility and challenges of using a predetermined set of unfavorable outcomes to compute a disease severity score, and also the prevalence incidence of confirmed Lassa fever co-infected with malaria. For Enable 1.5, 1,000 participants have been enrolled across 4 hotspot clusters in Edo State and are being followed up for 1 year. Currently, the study is in its 5th month. Yeah, it's in its 5th month and running. The difference between Enable 1.0 and 1.5 was that we wanted to know more about the asymptomatic cases. In 1.0, fever was a priority. A criteria for collecting blood, going to the health facility, being a suspect. Well, in 1.5, fever is not a criteria for being classed a suspect case. So we're broadening the case definition to pick even the asymptomatic people, those who don't present with fever. Aside from that, in 1.0, malaria was determined by RDC, our rapid diagnostic test. But now we're also looking at, aside from the RDTs, what about the microscopy? So there's the inclusion of microscopy in 1.5. So next slide, please. These are just a few of the community-based studies that we're carrying out. There are some that are still in the pipeline. There are some that will be rolled out this year, but we're doing a lot of community-based research. Thank you very much. Over.
Thank you, Dr. Ekaete, for that very elaborate presentation of the 3 case studies. Please, can somebody mute those that are not speaking? So, thank you very much. Particularly interesting about on the presentation, especially on the PPMVs, how despite knowing about Lassa fever, they will still practice work practice and all. I'm looking forward to the panel discussion that we are just about to step into, so that we can discuss more on that. So while Dr. Ekaete stays up, we would have, I would be introducing the speakers right now to join us as we take this discourse. So already we have Dr. Ekaete Tobin in the panel discussion. Secondly, we have Dr. Nyan DOUGBEH, the Director General of the National Public Health Institute in Liberia. He's a medical doctor and a biomedical scientist. He's leading MPHIL in Liberia. Then the third speaker, Dr. Namadu Keita. He's an expert. He's an expert in WAHU, an external expert resource person in WAHU, West Africa Health Organization. I would please. I know that they are all already on the call. I would let them. Can I confirm that they can hear me, please? Dr. Nyan, can you hear me?
Yes, I can hear you.
Great. Dr. Keita. So I would start off writing on the discussion, the presentation.
Oui, je vous entends.
Great. Writing on the discussion from Dr. Ekaete, I'm going to proceed with, and I'm going to, throw my first question to her, especially from the very first presentation, which is the role of proprietary and patent medicine vendors in community and facility-based research and surveillance for Lassa fever in Nigeria. So I'm going to ask Dr. Tobin, based on this research, right, you have noted in your presentation that while these PPMVs are very knowledgeable about Lassa fever, they still somewhat engage in unsafe work practices. And yes, most of them they have expressed the willingness to actively participate in Lassa fever response efforts. But how can PPMVs now be more effectively integrated to enhance community surveillance and early detection while ensuring their safety and while strengthening their role as part of the Lassa fever control structure? Over to you, Dr. Kate. So Tobin. Dr. Kaite, can you hear me?
Sorry, I was muted. Yeah, I can speak now. So thank you very much for your question. Our study found we found that number one, they have some knowledge, but we were able to identify the gaps in their knowledge. So if we start with targeted trainings, we need to train them. There is a potential for patent and proprietary medicine vendors to play a role in Lassa fever response because they're out there in rural communities, hard to reach areas where you don't even find a hospital, a health facility. You find a patent medicine vendor. So they do have a place in the response. So all we need to do is build their knowledge. What do I mean by build their knowledge? Train them. Now, these are usually, in our study, we found out that over 50% had tertiary education. We may not always get this number with having tertiary education, but at least they do have some form of education so they can be pulled together and trained. Training them, what are we training them for? We're training them to recognize symptoms. We're training them to at least do basic IPC, so hand hygiene, know the notification pathway, so know when to refer, know how to counsel, know how to address stigma. These are areas we could train them on. If they are trained, if they are empowered, they would surely be they will be advocates. Now, not only training them, providing them with the IEC materials they need. So like posters in their retail shop, in their shops, where they hang and that are hung and they can make reference to, to broaden their knowledge. Access to resources, resource persons. If we give them the phone numbers of the DSNOs, they can always call when they have a challenge, when they see a case, and they're not too sure, they can call to refer. So if we train them, they will be community informants for us. In fact, in some LGs in Nigeria, patent and proprietary methods are part of
ressources dans les communautés.
community informants and part of community-based surveillance system. So there is a potential for them. When we train them, we have to train them. We have to supervise them. So from time to time, the DSNO goes there, or the resource persons go there from the local government, from state, see what they're doing, give them more materials, help them build their confidence to be able to speak to people. They have people coming in who they would sell anti-malarials to. By the time they engage the people and see that they are not responsive, what would they do next? To refer. So I think they do have a role in, and they can be trained. And if they are trained, they'll be able to perform this role. Building their knowledge is just by training them. Thank you.
Right, thank you, Dr. Ekaete, for that answer. I think yes, it's undeniable what their role is, especially in the community level. But then for us to be able to leverage that, we need to make sure that they are trained in terms of having the capacity, and especially on IPC, so that they're able to also practice safe work practices. So I'm going to also, still on the PPMV still, can I ask what challenges these PPMVs could face in identifying, in addition to the training that you have mentioned, in addition to building their capacity to be able to recognize symptoms, to be able to practice safe, to be safe in this community surveillance system now. What other challenges do these PPMVs face from your study in identifying and referring suspected Lassa fever cases, in addition to the training? How can we better integrate this into the outbreak response efforts in practice? Dr. Ekaete, I think you're muted. Can you kindly unmute?
Yeah.
Also,
thank you. I'm muted again.
Okay, that's fine.
Can you hear me now?
Recognize. Yeah. Yes, I can hear you. I also do recognize that, like, if you can give examples in terms of like the strength of referral system, for example, in terms of the if there's something infused in it for the task shifting and task sharing policy and all of that.
Thank you very much. So can you hear me now? Okay, so after training, you see, it's one thing to train, and then another thing to empower them, create the environment for them to be able to do what they are doing. Now, the people they are going to speak to are people who may have fear and distrust for the government's health sector. So even when they spot these cases, the people come to them, meeting case definition, they have had this fever, they've come back to complain that their fever is not receding, it's unabated. And they ask them to go to the health facility. Fear and distrust. Fear, one, logistics. How are these people they are counseling, how are these people they are talking to going to get to the health facility? Two, financial. Who is going to pay the bills? These are resistance factors. These issues will always come up. And except these issues are tackled, there's always going to be that challenge patent and proprietary medicine vendors have with this role in Lassa fever. So stigma is another thing. Nobody wants to be labeled a Lassa fever suspect. So even when you've empowered them, you've trained them, you've put in them the skills to recognize, you've given them the DSNO numbers, people will be unwilling because of existing stigma in the society. People don't want to be labeled as Lassa fever suspected cases. Now, these are challenges. And then the patent medicine vendors themselves, they also don't want people fearing, they also don't want people to feel that when they come to their stores to buy drugs, the news will spread that they are sending people to the hospital for Lassa fever. So there are issues. But all this can be addressed if there is a concrete formal system in place to engage this potential source, engage these people and make them integrate them into the surveillance system, integrate them into the Lassa fever response. All these challenges will be blocked. So they do have challenges, but they can be addressed. Thank you.
Thank you very much, Dr. Ekaete, for that. It's definitely these are things that can be addressed, and they can be addressed when we incorporate them formally into the structure for Lassa Lassa control, response and control. So before I get into some of the ways that we can strengthen the surveillance system, still on engaging the PPMVs for Lassa surveillance, I'm going to be asking you one more question, and in relation to the knowledge gap, which you've already spoken about. So in this study now, right, you found that primary health care providers in endemic communities had poor knowledge of Lassa fever. So what would you what kind of targeted strategy, what targeted strategies do you think she employed in terms of improving their preparedness, especially for frontline healthcare workers and their response capability? Okay, Dr. Ekaete, please can you unmute? Sorry.
Thank you. I am of the opinion that training should start at undergraduate level. So at undergraduate level, Lassa fever is built into the curriculum. So these health workers start hearing about Lassa when they're in their undergraduate years, prevention and control. By the time they come out and they are working, training, there's no end to training. So organized in-service trainings, pre-service trainings, all those, particularly when you're situated in a Lassa fever, an endemic state or an endemic country, you must carry out these trainings periodically for everybody who is entering new employment. For every new employee in a health facility, there must be training on Lassa fever. Then periodically train. Now, during outbreaks, you have to sensitize health workers to raise their index of suspicion. Teach them about the symptoms, teach them about case definition, teach them about referral pathways, teach them about how to protect themselves and their staff in their facility, because we know that Lassa fever is very easily spread by it's nosocomial, can be a nosocomial infection. And the health worker mortality is usually high among healthcare workers because of our poor IPC practices. So training now to these healthcare workers who are in the primary level, they are actually the front line. The patients they are the ones who see the patients first before they even get to the teaching hospitals. IPC training is mandatory. Basic standard precautions is a must. You must train them how to safely use PPE when they identify suspected cases and use the appropriate PPE. Waste management, very important. Hand hygiene, very important. So that is training. Then, just as you would with the patent medicine vendors, you cannot do without workplace reminders. That is why we have posters. That is why we display roll-up banners on hand. We share them at each outbreak. We're sharing posters in healthcare facilities to serve as reminders to health workers. Why are you doing this? Not only should they refer their patients on time, but they should protect themselves. So training, and then there are many online resources, that we can refer health workers to. There are online platforms. WHO sponsors Lassa fever courses. There's a platform on infectious diseases. We can encourage health workers at the primary care level to go online and take part in these courses, online courses. Inviting them to be part of outreaches, to be part of awareness campaigns is also part of training them. They hear firsthand they also hear the experiences of patients. They also get to know the challenge. By the time a patient comes to their facility, the patient may have gone to several other facilities. So by the time we are seeing these patients, the patient is already 6 days with Lassa fever. She may not even give them a history that he or she has been through several facilities. We'll just give them the immediate complaint. And if they're not trained, so that also speaks to the level of kind of training we give our health workers. If they don't take a detailed history, they miss it at that point. So training, we cannot overemphasize training. And then I particularly also think that giving rewards to health facilities that do refer patients is very good. Why? Because we know that along the line, some people may be tempted to try out. They have this confidence that they can treat Lassa and keep the people because they know that a lot of them are, even the mild ones do recover on their own without reverberating. So the other practices that the different health professions should regulate. For example, here we have this law that you are not allowed to treat Lassa if you are Lassa should not be treated anywhere else except that should also be incorporated into trainings. You cannot treat Lassa, refer. So there's no end to training. Training. We're emphasizing the different trainings, particularly during outbreaks, giving them refreshers, encouraging them to do online learning, go to online platforms and learn from the many courses there, and building it into undergraduate training programs are some of the suggestions I have. Thank you.
Thank you very much, Dr. Ekaete. You've touched on some of the next question that I was going to ask about. I'll circle back to you on some of the things, some of the strategies that we can use to strengthen the referral system. But beyond that, I'm going to move over to Dr. Chris. In his work, in Dr. Chris's work, in his work in diagnostics, particularly with relation to the Nyan test that he led the development of. This Nyan test, from what we know, can detect multiple infectious diseases within minutes, So this diagnostics tool, how, can you shed more light on it in terms of whether it can be used for detecting Lassa fever, and maybe more broadly on how innovations like this can improve community-based surveillance and research for Lassa fever? Over to you, sir.
Thank you very much. I don't know if it's the time for my presentation, but to handle this question immediately. Certainly, the test is a multiplex isothermal test designed to be very rapid and economical, as well as very mobile, so that it can be deployed in hard-to-reach areas, given the inaccessibility of most of our terrains on the African continent. The test is designed to suit particular diagnostic regime. Say, take a situation where we may have diseases of similar onset clinical symptoms like Lassa, malaria, typhoid, which come with fever and other similar clinical symptoms. The test is meant to simultaneously target all of these 3 or 4 infections together and detect if they are present and then distinguish them as well. So that makes it very easy for healthcare workers, particularly epidemiologists who are into diagnostics, to use such a test in hard-to-reach areas. And the test is also, as we said, designed to be economically affordable. One of the drawbacks is that it has been proposed to the West African governments, particularly since 2016, when I served as national orator of the Independence Day celebration in Liberia. But I don't want to say, the drawback is that our own countries have not come forth to invest in developing this kind of affordable test. We still rely on Western developed tests, still spend a lot of money importing them or depend on those situations. And so in my presentation that should be coming up is one of my appeals that we should look at local talents, local resources, and local innovations, which can be utilized to address our problems on the African continent in terms of healthcare and public health. The problems are ours. As we can see, the drawdown of usage or the withdrawal of usage from most of these projects around Africa has impacted most of our healthcare settings and our health delivery, as well as looking at how we can address issue of diagnostics and surveillance and response, etc. So I hope I've, in summary, addressed your question.
Right. Yes, you have very elaborately responded to them, my questions. So in terms of the presentation that you had made reference to, perhaps let me take a question from Dr. Keta, and then I will circle back to you. We'll give you a couple of minutes to take the presentation, and then I'll ask you the next question. So I would circle back to Dr. Keta. In terms of all the discussions that we have been having, Dr. Ekaete had highlighted some of the things in terms of leveraging PPMVs to manage Lassa fever. Dr. Chris has also mentioned this Nyan test, very innovative diagnostic regimen that is also economically affordable, that could also be leveraged. Now, at WAHU, I know I am aware that WAHU is currently developing a framework to guide community health principles and standards across the ECOWAS region. Now, in what ways do you see this framework enhancing and promoting community-driven research, particularly as it relates to Lassa?
Merci de m'avoir donné la parole. Ici, je parle un peu au compte de l'Organisation ouest-africaine de la santé. Dans ce
in this webinar, I would like to, at the very beginning, mention two items relating to the community issues. We noticed that since about the Declaration of Almata in 1978, Africa is not having a real engagement of the community. The morbidity level is visible. It's important to notice that our approaches enabling to address health issues are mostly focusing on the curative to the detriment of prevention and surveillance at the community level. That's why WAHU, which is a specialized health institution,
prévu de s'investir dans une réflexion stratégique régionale avec toutes les parties prenantes clés en vue d'obtenir un large consensus sur les normes fondamentaux de la santé communautaire. Cela constitue donc un cadre régional stratégique qui permettra d'aligner les parties prenantes sur une nouvelle orientation de nos approches de santé en général, mais surtout de la santé communautaire en particulier. La recherche sur la fièvre de Lassa devrait prendre en compte les normes et principes consensuels définis par ce cadre. Il s'agit essentiellement de se mettre d'accord sur une définition claire du concept de communauté. J'avoue que la plupart de nos systèmes de santé ne prennent pas en compte ce que c'est que la communauté et leur engagement à accompagner les actions que nos différents secteurs mènent à leur niveau. Et aussi, il est important de savoir quels sont les acteurs communautaires que nous devons engager en première ligne. En particulier, ce que beaucoup de pays appellent les volontaires, que nous pouvons appeler ici des agents de santé communautaire de base, doivent travailler sur la première ligne, c'est-à-dire dans les ménages, et essayer d'être plus fréquents dans les ménages en raison une fois par semaine ou une fois chaque 2 semaines, de sorte qu'ils ont l'œil sur tout ce qui se passe dans les ménages. Ils sont alertés sur tous menaces de santé publique et remonte l'information au niveau des structures de référence de proximité. Et ceci nous paraît très important. Ces agents de santé communautaire de base doivent être supervisés par d'autres qui sont à un niveau plus élevé, qui sont des agents de santé communautaire qualifiés, qui doivent superviser les actions et qui vont faire l'intermédiation entre ce premier agent de première ligne et les structures de référence. Il est aussi important dans ce cadre stratégique régional de santé communautaire de noter le mode de gouvernance locale qu'il faut privilégier
in order to guide, the activities. We should know the role of the communities, the prefecturates, and based on the decentralization of every country and based on the various policies that can play an important role in all the guidance activities. So we have to agree on the appointment mode of the community-based, health workers, for them to reflect, the beneficiary, the communities. We have to agree also on the funding, the sustainable funding, the system that is the member countries agree on the payment, pattern for these stakeholders, for them to be good health workers at the community level, and set up mechanisms that will secure their works as well. So it is highly important, this framework, to consider the activity package of the community-based workers, focusing not only on the curative, but also on preventive, promotional, and at the community level. They have to be endowed with information system, or enabling to take up information systematically, so that any event that will occur in the households be taken up to the highest level. So WAHU is planning under this strategic framework to develop, a standard document on community health that will be taken through, a resolution, the assembly of the ministers, and all the donors and the technical and financial partners will agree on that, so that in each country we'll be able to adapt to our specific context. That's what we can say so far, and we believe that the research on Lassa fever should include these norms and principles in this document, and researchers should go deeper to define the role that these health workers are playing, and the policy makers play as a role.
Communauté. Ceci est très important. Voilà ce que je peux dire en guise d'introduction pour cette question. Merci.
Thank you very much, Dr. Keita. One very key thing that he has mentioned is how countries often just prioritize corrective measures and treatment over to the detriment of prevention and health promotion. And we all do know that that we need to prioritize prevention. We need to prioritize health promotion now, so that we are averting some of those things that we can meet at the correction junction. So while I take on the next question very quickly, building on what he has said, I would request that Dr. Chris actually shares his presentation to the team, so we're able to project when we get back to him right after Dr. Keita. So now, Dr. Keita, you've given very valuable points in terms of health promotion and disease prevention as very key pillars for public health and for managing Lassa fever in general. So many African countries are working to strengthen these areas, but how can we, leverage, how can this effort now, especially from your lens as WAHO, how can this be leveraged to enhance Lassa fever research and Lassa fever response efforts at the community level? If you can, speak more on the community surveillance base, that would be very helpful.
Oui, merci. Merci. Je peux dire que le système de santé communautaire promu par l'OAS et ses partenaires au développement implique à la fois plusieurs acteurs. Hein. Nous avons les agents de santé communautaire qu'on appelle aussi relais communautaires. Nous avons les centres ou postes de santé de proximité qui offrent donc les services de soins de santé primaires. Nous avons les chefs de ménage qu'il faut prendre en compte ici comme un élément très important parce que c'est pour eux que nous mettons tous ces systèmes en place. Nous avons des responsables des communes ou des municipalités, des responsables d'autres secteurs au niveau local comme le secteur de l'élevage, le secteur de l'environnement, le secteur de l'éducation, eau, hygiène, assainissement, etc. Ceci démontre à plus d'un titre l'importance de l'implication de tous les secteurs de développement dans les questions de santé. Et c'est ce que nous appelons la santé dans toutes les politiques, qui est prônée depuis longtemps, mais dont, en tout cas, il n'a
for a long time, but is not still having a lot of success. So when we take the specific role of these community-based health workers who are frequently, regularly in the households, he or she is in permanent contact with the beneficiaries of his or her activities. And share you.
De santé qualifiée. C'est cet agent qui va donc identifier les ménages où il y a ces événements et accompagner à l'identification aussi des cas contacts, etc., au sein de sa communauté. Il va être vraiment un élément très important lorsqu'il y a une épidémie de n'importe quelle maladie à potentiel épidémique, mais en particulier en cas d'épidémie de la fièvre. Alors, nous pensons qu'au niveau régional, sur la prévention et la riposte à l'épidémie. Je vous remercie.
Unfortunately, I couldn't hear a lot of what Dr. Keda has said because I think the audio of the interpreter is affected by network. So I might not be able to, respond. But one thing that what he made from what he said is a lot of the development sectors were involved in the development of the framework. It would have been helpful to have known, to have had the full detail. However, the network is pretty bad. I'm going to now circle back to Dr. Nyan. Are you able to take your presentation now?
Yes, I can. I will prefer sharing it from here so that I just present on selected slides since of the information presented may have already been covered before.
Okay, thank you. Please go on. Okay, are you able to project now? The admin have given you permission to project. Great.
Yes, I think I've projected.
Yes, you can see your slides now. Please go on.
Okay.
Yes.
Okay, thank you very much, colleagues of the West Africa Health Organization of ECOWAS and those of our colleagues online. I'm presenting here on behalf of the National Public Health Institute of Liberia, which has received quite an enormous support in recent times and in time past from WAHU. Thank you for the facilitation of the cross-border exchange of experience with the Ivory Coast recently, and that which you also carry over to Ghana. We look forward to organizing one with your support with Sierra Leone and Guinea, so that we would have then covered the Mana River Union. I know an overview of Lassa fever, which is a hemorrhagic fever virus, has probably been covered before I came on. But again, it's a single-stranded virus, which is 7.1 kb genome. As we all know, is zoonotically transmitted through rodents to human. It was identified in Nigeria in the 1960s, and we have had several outbreaks over the years since then in Sierra Leone, Liberia, Guinea, Nigeria, and there's a whole belt stretching from Nigeria to Guinea, which is the Lassa belt. We know the amount of approximate cases that we have per year, over 500,000 within the region, and with some deaths as well. The mode of transmission, I probably believe, has been covered, and we say is from mice, dung and urine on food and utensils that we have in our homes, which then are contaminated, and then the virus is transmitted to human. The cases are about 80% mild, 30% create deafness, often which is permanent, and we also have 20% severe cases. This data is from the General Institute. The important thing that we wanted to stress here in this presentation, given the fact that we are looking at this transmission, genetics, and community engagement, first is the fact that we as African, particularly West African scientists confronted with this disease, have to look at the genetics in order to come out with approaches to therapeutics and prevention. We cannot do that if we don't look at deep down biomolecular serological research. So there are roles of certain glycoproteins which are responsible, tend to be responsible for pathogenesis, like the glycoprotein 1, 2, which are in the Lassa fever virus. I raised the question as to what is the role, what could we find as the role of LAMP1 in the transmission? Because if we can break the transmission chain, then we would have done something very, very effective in reducing or curtailing the Lassa virus outbreaks in our countries. And so look at slide B here, gives you a cartoon of the glycoproteins that are responsible. And so this is a challenge to us biomedical researchers, public health practitioners alike, to look into this and deep dive, where the previous speaker, our colleague, talked about proprietary medications and all of that. If we, as the African continent, led by the Africa CDC and WAHU and WHO Afro, are now looking at deep down research and development on the continent that will be African driven, then we must begin to look at these aspects as we look at Lassa fever infection in our countries. So we then So the question that I raised earlier was, these have implications for therapeutics and preventive measures. So are there any genetic mutations of concern that we need to look at? Those are questions that I think we need to answer. Again, as we indicated, from a public health standpoint, we know that there have been epidemics over the years since 1960. How is our surveillance capacity in these endemic countries? If you look at the map of West Africa, you see where the outbreaks have occurred repeatedly. The red dots indicating outbreaks and the blue dots indicating serological evidence of zoonotic or human-to-human transmission. So how do we curtail this? We need to understand how this cross-border transmission take place. So from an epidemiological public health standpoint, is something that we need to look at in order to also, as the previous speaker said, look at economic factors, which she in detail delve into. But I want to draw our concern to regional and international collaborations on the technical aspect of building our capacity during outbreak response. Currently in Liberia, and as you will see the slides later, there are several collaborations. I know CEPI has a supported project here, but what we find is that these projects are not ingrained in our own programs and research capacities. So can these international collaborations be redesigned so that it takes into account the country's specific interest in capacity building? Capacity building, not just from the human personnel aspect, but from the technological side as well. So we have the U.S. Centers for Disease Control, which also has supported projects around our countries. The Nigerian CDC, the Liberian Public Health Entity, and countries around the world, around Africa, particularly in Mali. We also have the EU partners and EU government partners. Can these capacity building and international collaborations be tailored to country-specific interest? And I would now say region-specific interest. So we as Africans, public health personnel, we have to breed in these collaborations our interests. What do we want as we look at Lassa transmission and Lassa outbreaks on our continent? This epic curve shows you Lassa outbreak in Liberia from January 6, 2022 to March 2nd this year. So here in Liberia, we have had a sustained and prolonged outbreak for the last 3 years with some intermittent resting periods, I will put it in between. Like in July 2022, we saw no case. And up to now, we are dealing with just a few cases because of the way we've been able to case manage it. So you can see we have had a lot of patients surviving, they are alive, but we have a lot of fertility also. The current table here, which you should please ignore, but look at mine arrow here, pointer, the cases, total confirmed cases between January 6, 2022 to March 2nd, 2025. In this case, 184 were confirmed. We had total deaths of 56. So you can see how at least we have been improving just a little bit. And this dashboard will show you exactly where we are now, just accounting for January 1st, 2024 last year to March 2nd this year, where we have presently 0 active cases out of 46 total confirmed cases that we had in this period. We had 12 deaths. Yeah.
So, Chris, is it possible to run within 2 minutes? We because of time constraints, we'll be able to give participants time to engage.
Yeah. So, in raising in raising awareness, approaches that I think we need to take as public health personnel and biomedical researchers is raising of awareness and educating the people about the disease transmission. So community engagement is very, very important. And we have been doing that from the side of the National Public Health Institute in collaboration with various partners that are here. Promoting preventive measures such as hygienic education, cleaning homes, proper storage of food, proper waste disposals, promoting rodent control strategies, which we have been evolved into, looking at early detection and reporting, which we need to educate the community about. Community mobilization in this regard is very important. And also very cultural consideration has to be taken into account. And now, one important thing is we think increased national and regional budgetary allocations for these purposes will be necessary and important so that we don't depend on outside or external aid like the USAID now, which has been discontinued. And of course, collaborations of regional scientists in the fight against Lassa will be very significant, as we are doing now with Ghana, collaborating with Noguchi and other entities. Thank you.
Thank you very much, Dr. Praise, for that presentation. But I'd also like to, highlight what he had said towards the ending in terms of emphasizing the need for community engagement for combating Lassa fever, but most especially for this community engagement activities to be incorporated in budgetary allocations and for this to be done in collaboration. So I'm going to, because of time, I have one more question for the panelists, but I will just, go to the Q&A session and give opportunity for the participants to ask the panelists questions. I already see one hand up. I don't know if it's a legacy hand, but I would call on Adejinka. And also, we have a Q&A chat box as well. Please go on ahead and drop your questions there while I read out the ones that are already written. Okay, so far we have a couple of questions, so I'm just going to get onto it. One for Dr. Ekaete said you're suggesting giving incentive for facilities that require Lassa fever tests. Can you identify a sustainable approach in providing these incentives and also the source of the incentives? Specific on the sustainability and how that source the source of it would be. And then we also have one for Dr. Nyan, but I will just let Dr. Ekaete go on first.
Apologies, please. I was logged out. I didn't. Can you take
Dr. Ekaete, if you're speaking, I think you're muted.
Yes. Can you take the question again, please? I was logged out. Thank you.
Okay. So, Dr. Ekaete, you suggested somebody's asking based on the incentive that you have recommended for.
Hello?
Can you hear me?
Okay, I can hear you now.
Okay. When we were discussing, you had mentioned giving incentives, incentivizing the reference from the community and all of that. So the question is identifying sustainable approaches for this, and if you are recommending incentives, what would be a more sustainable approach for it?
Okay, so can you hear me?
Yes, I can hear you.
Okay, thank you. It doesn't always have to be monetary, even just ensuring that they get a pack of protective equipment, so ensuring that they get hand sanitizers is another way of incentivizing them. So making them part of trainings, giving them a certificate, just we can actually do simple things to make these people feel motivated to work. Definitely stipends would be helpful, can come in. But where there are no resources, they should also be encouraged to do voluntary work. So this is part of their support to their community, part of it's a communal good they are doing. But it's not out of place to, from time to time, give them rewards, not necessarily monetary, but also in kind. I think that should be encouraged. For the healthcare facilities and healthcare providers that actually want to always refer cases, that are very vigilant and refer, making them part of programs, again, it's another way of rewarding them, giving them, at the end of an outbreak, you give them a certificate to acknowledge their dedicatedness to referring cases and supporting the response. Is not out of place. These are all ways that we can encourage healthcare workers and patent medicine vendors to be motivated to support the response. Thank you. I hope I've answered the question.
Yes, while you're still here, can you provide more clarity on the consumption of Gary from Enable 1.0 study? Whether this Gary is sold with rodent is before human consumption? No.
Sorry, please take that again. I didn't get your question.
I think the person is asking for more clarity on the consumption of Gary from studies from the Enable 1.0 studies.
Yes, over the years, Gary consumption, because of the frequent messaging during every outbreak, even in between outbreaks, there's been a lot of messaging to people to reduce Gary consumption. But now we're also saying, if you do have to do it, because some people will always be stubborn, then fry the Gary a little bit and make sure you protect it from rodents, keep them in covered containers. So while we cannot say that it's reducing, we can say that people are getting more knowledgeable on how to protect their Gary source so that it doesn't get infected with Gary, with the rodent excreta. So the practice is still on, but of course people make it safer. Yeah. Thank you.
Okay, I'm also trying to scroll through. We have a number of the questions. It seems that most of them are also targeted, are being directed to Dr. Ekaete. So I will take two more and let you respond. The first one I would say is about how Edo communities participated in these studies, particularly for the communities. I know that you had mentioned that in your methodology. If you can just, say a few words on that, and then if you have any background in terms of practice that have of these people in the communities doing the research.
Okay, I'll take the first question because I heard it, but the second one I did not. You were talking about communities participating in research, right? Sorry, the line was breaking a bit when you were speaking. Well, your first question was on what, please? Can you repeat it?
The first one is on how the methodology or how the communities in Edo participated in the study, in all of the studies.
All right, thank you very much. All right, thank you very much. So in all our studies, we always start with community entry. So we have to go to the traditional rulers, the gatekeepers, depending on the level of the study. If it's a study that is just at community level, we have to go to the traditional rulers. Tell them about follow traditional rights, tell them about the study, get their buy-in, get their support, get their blessing. Now, if it's a study that we need to go to the state government, we've had a study where we had to go to the State Ministry of Health. And from the State Ministry of health, we came down to the local government level, to the local government chairman. So we do involve them in studies before actually getting to the households, to the participants of the, want to engage in the study. After we've gone through the community leaders, we now get to, depend on the study, we can hold a town hall meeting where we call potential participants together and give them a talk about the study, just get them informed that they have opportunity to ask questions, or we go directly to the households. Now, again, you have to pass through the head of household. He has to give consent. So we walk through that process. Even when we get to the individual, we still have to follow ethical guidelines, ethical principles. So we consent them. Then again, so that's their participation. Then even in sense of recruiting, gathering communities, depending on the study, depending on our objectives, depending on what our focus is, we can either pick high, depending again on what the focus of the study, we can pick high burden communities against Lassa fever, or spread the mix of high burden, low reporting to see if there's a difference between the two. Again, like I said, depending on the focus. So basically, in short, what I'm saying is we pass through the steps. You do your proper community entry, do your community mapping. Who are the stakeholders? Who do I need to talk to? We've had an instance where we did all this, then there was a rumor that started in one part of the community, about what we were doing from people that were not involved. We were in a different section of the community. We have to go in. So community engagement, even at that, is a continuous thing. We keep at every predetermined points within the study, we keep engaging them, keep letting them know this is why we're here, keep giving them, in fact, from the beginning, they have to be part of what we're doing. So we bring them in. They are even part of shaping what we're doing, helping us with the communities to target, directing us on who to meet at the particular quarter we want to meet. So it's a whole flow of work, workflow. We don't just jump in. There are we really have to take time to go through the community leaders, engage the own heads of households, so that we have that commitment. They're part of the study. They feel the study benefits them. They're contributing to the good of their community. And they stay engaged. Even the patent medicine vendors I spoke about, we had to go to meet the expo. We had to go to their executive. Yeah. Sorry, are you hearing me? We had to go to meet the executive, yes, tell them about the study. Yes, we had to go through all that. Thank you. Over.
Yes. Thank you very much for that very elaborate answer. So because for want of time, we'll have to round up the question and answers. We'll not be able to take more questions. Sincere apologies for that. And I do see some of the comments or some of the messages on the chat box around how it's important for PPMVs to be engaged, how they need to be involved in the development of the initiatives and all of that. And also a lesson that I learned from Integrate E, leveraging, having formal structures for PPMVs for family planning, and that can be duplicated, or lessons can be learned and implemented for Lassa fever. So I'm going to call on the speakers now, just in 30 seconds, to give closing words on this. So I'm going to start off with Dr. Chris in just 30 seconds in terms of responses to all of the discussions.
Okay, thank you very much for this very important webinar, which has highlighted the need for our region to focus on this disease that is a very serious burden, which is Lassa fever. I think to summarize, all of the speakers have been able to give us an idea as to how we should approach it, both from the community advocacy level, community engagement, and we spoke about the need for all of us as African public health personnel and researchers to also focus on those things that would make us independent in our approach to not just Lassa, but other diseases of interest. Preparatory medications, we can focus on research and development and innovation that will help us developing our own medications. We have the talent, we only need the support. And so thank you very much for the opportunity to share my ideas with the rest of the continent. Thank you.
Okay. Dr. Ekaete, any closing thoughts on this?
Yeah, thank you very much for inviting me to speak. Thank you to the audience and all the other organizers of this program. I think the take home
I
for
don't
me,
think I should have done this closing.
The take home for me is that we need to build our capacity as researchers in Africa to carry out high quality research. We need to open this field and draw in people, sponsor people to attend courses, to be able to run, starting from writing a good proposal, then funding. You're not able to get funding from external, the developed world, but building our, funding base that we African scientists can tap into and carry out our studies, and supporting with publications, the public publication fees and presentations at conferences. Now, making sure that we keep communities engaged is paramount. So if we build communities to know how to be part of research, it becomes easy for them to key into research proposals that we come to sell their, share their ideas with us, be part of developing the proposal. We now have communities who are used to research. So running a clinical trial in a community, not just for Lassa, for any other infectious disease, doesn't become difficult because the communities are used to research. They are also informed and they are positive towards demanding that results, government and leaders use the findings of results to improve their well-being. I think if we can do all this, we would really benefit from the many research that we have done that are published out there, translating this, what is written, to policies and processes that better the life of Africans. I think for this will be successful. Yeah, thank you.
Okay, thank you, Dr. Apologies for going over the time. The plan was to finish at 30. And I should apologize for that. I'll just take the last few thoughts from Dr. Kaita, and then
Oui, vous m'entendez? Allô, vous m'entendez?
Yes, I can hear you. Yes, we can hear you, Dr. Kaita.
OK. Merci beaucoup. Alors, en résumé, je peux dire que tout ce que nous faisons pour les communautés, sans les communautés, est contre les communautés. C'est important de bien comprendre les communautés.
So it's important to understand the communities under this research on Lassa. Any research directed to the community should be done so, and we should get them all involved from the beginning of the research on Lassa fever, and also have to maintain the engagement of the community throughout the research and until we get the findings of the research. So, and the findings should be very simple and understandable by all the communities. The result of the research should be formalized or worded in such a way that it is understandable by everyone, especially the community. So it's from the beginning to the end. So our publications have to be accessible by these communities. Otherwise, we will be talking with the scientific circle, but the community will not accessing, the result. At the beginning, Wahoo, who is developing a document, a reference document for research on community-based health. So we will be able to define their role, but also how we can approach the community-related issues with the beneficiaries, and Wahoo will remain available to accompany research in our sub-region. Thank you so much.
Thank you very much, Dr. Kaita, for that closing words and the emphasis on health prevention and health promotion through our community-based system. So I'm going to, as we round up, this is something that we should just continue to put at the back of our minds after this very valuable discussions that we've had on in terms of integrating community actors in the surveillance systems as we combat Lassa fever, and also to leverage this diagnostic that Dr. Chris had mentioned for rapid detection, as well as also strengthening and implementing these regional frameworks for community health. And most importantly, at the forefront of this is to involve the communities in the development of the initiative. That's something that have come out in all of these discussions and even on the chat box. So I would like to thank also our panelists for their very valuable contributions and for engaging in this, and also for the participants for engaging actively in this discussion on the chat box as well. Let's continue working together to strengthen community-based research for Lassa fever across West Africa. So right now, I'm going to hand over to, we're going to pull up a document while we start to round off. And I will invite Dr. Virgil to speak to the Lassa conference. While we are already talking about in the inclusion, as we are combating Lassa fever, right? There's also an announcement that Dr. Virgil will make.
Thank you so much.
On the chat box, feedback link or give feedback on this web.
Yeah. Thank you so much, Oluma, for the opportunity, and thanks to all the speakers, panelists, participants. I really enjoyed the conversations this afternoon. A lot of discussion and engagement in the chat box as well, and we look forward to continue this. We know that the 90 minutes for this webinar is very short, but it's also important to maintain it focused for us to be effective. So it's also my privilege to let you know more about the Lassa Fever International Conference that has been announced earlier. I can say by the end of last week, actually, by the WAHO DG and also the Director General of the Coalition for Epidemic Preparedness and Innovations. So after the first Lassa Fever International Conference organized in Nigeria in 2019, WAHO and CEPI are initiating the second conference to update the Lassa fever agenda and also advance the work that have been done at a regional level with regard to Lassa fever. So the objective of the conference are as follow. You are seeing them on the left, on your left side of the slides. Is really about enhancing the regional coordination and cross-country information sharing to boost the research and medical countermeasures, to discuss also about the outbreak response and disease surveillance capacities, community engagement, and social science approaches. We have started this afternoon already. So all this preparatory discussion will be informing the upcoming Lassa Fever conference. The conference will basically take place in Abidjan late in September, from 22nd to 26th September. And you are all invited to participate, to submit your abstracts. The call for abstracts will be launched by the end of this month, hopefully. And as soon as it's out, it will be widely disseminated. And I really thank all colleagues supporting this agenda, and in such a way that we can learn from what is happening in terms of development with Lassa fever, to inform other emerging infectious disease prevention and control, and also strengthen our health system broadly. So As you know, WAHO is fully engaged in an end-to-end approach, encompassing training, experience sharing, sharing of best practices, capacity building at national and regional level, and we look forward to continue more. And we need your support to advance this regional agenda under the leadership of the Lassa Fever coalition led by His Excellency Professor Mohamed Pate, Minister of Health of the Federal Republic of Nigeria. So it's really my pleasure for having you all this afternoon on this platform. We are over time for almost 10 minutes, so I don't want to be long. So I wish you a very pleasant afternoon or evening, wherever you are. So Oluoma, do we have any last announcements? Otherwise, we believe that it's really a pleasure for us to end this webinar on the positive note shared by our speakers, but also on the announcement of our upcoming conference in September.